want to acknowledge a lot of support that we've had for this work, primarily from the university, but also from other settings. And I just want to say that a lot of what I'm going to be presenting here, and I'm going to kind of walk through a lot of different data analyses, and it's been a real group effort from people in the department, in top health sciences, and across the university. There's also data that was developed in collaboration with the Division of Public Health here in Wisconsin, and we also have a collaborator at the University of Denver. So, a lot of this work involves really amazing efforts by a lot of people. So, my objectives today are going to talk to you about some state data sources that we have, because when I was growing up in the healthcare system, I didn't realize that there was all these population level surveillance data sources out there. I'm going to talk to you about some, but there's tons out there. But it's a complement to what we consider to be our fundamental source of information, which is our electronic health record data. But it's really very complementary. I'll talk with you about health disparities in Wisconsin. I'll explain population health and health impact frameworks, some of which were developed here. We'll take a little bit of a tour through some aspects of healthcare in Wisconsin, and this is sort of the keeping it real piece. What does preconception care look like, prenatal care and postpartum? I'll use a couple of examples from those, and then maybe we can have sort of a brainstorm of where we think maybe there's some opportunities to do better. All right, so let me just go back and remind everybody that a lot of the data that we use to understand important health outcomes like infant mortality, rates of preterm birth, come from the U.S. Standard Certificate of Live Birth. And just in case you weren't aware, there is a ton of information in these birth records. They are completed at birth hospitals before mom goes home. The data is kind of a collection of information that comes from mom, comes from her prenatal care provider, comes through the course of their hospital stay. And it's all entered into an electronic system and transferred to the health department, and this happens across the country. So this is where we get population data about really critical health outcomes, and we can use these data to really understand some of what's happening nationally. There's another data system that you guys may or may not be aware of called the Pregnancy Risk Assessment and Monitoring System. This is a postpartum survey that is sent to your moms. Now, it's not sent to everybody, but it's sent to a sampling of moms across the state. And it asks them a lot of questions about themselves, their family, their reproductive history, and about their experiences of healthcare before they were pregnant, during their pregnancy, and since they delivered. And that gives us a really important window into what, for this purpose, into what healthcare looks like for women, but also, what their lives are like. And I'll be showing you some data from Wisconsin and some national data. The postpartum survey is linked to the Standard Certificate of Birth at the state, so we can then take mom's survey results and match it up to what her birth outcomes look like, and use this to really understand what's driving health. It's weighted to be population-based, so if you want to ask the question, what percent of women in Wisconsin, we're able to do that even if you don't sample everybody. And it's fielded in nearly all U.S. states. Notably, it's not fielded in California. They have their own version of grants. But you can use this to also compare what things look like in one state to the next. And then I have a tiny little bit of data from a big integrated data project that we embarked on a couple of years ago here, where we link these birth records to a lot of other sources of data, including Medicaid claims, some social services data, some geographic data, as well as educational data. All right, so let's start with sort of the big picture. Infant mortality, like other mortality rates, is really a key indicator of the health of the community. And what's particularly compelling about infant mortality is it's very sensitive to a lot of really critical factors in communities. So it all kind of culminates in these measures. And what we can see from this data here, and this comes from birth record data, is we see there's really been a dramatic improvement in infant survival over the past century. And here we see, starting in 1940, both infant mortality, neonatal mortality, so death within the first 30 days, post-neonatal from that 30-day period to the end of the year, have all really plummeted. And I think we all probably understand that a lot of this is not due to healthcare. But there's a significant piece that is, we start out by improving community conditions, increasing, availability of clean water, decreasing infectious diseases, and we see a big drop, but we also introduce neonatal intensive care units and surfactant, and so infant survival has improved, because of both community interventions as well as healthcare interventions. But it's we're kind of losing the battle of continuing to see decline, and it's really gotten much more flat. Wisconsin, so this is data looking at infant mortality overall in Wisconsin. These data are from 1985, and what we see is, Wisconsin's data mirrors the rest of the U.S. We've seen a continued decline since the 80s, but then really a flattening here in the state. What's really key, though, is to understand that even though we saw this tremendous improvement, our ranking has actually slipped. We used to do better than many countries, but what we see here is if we look at other OECD countries, so other developed countries in the world, our infant mortality rate really looks pretty poor compared to other similar countries. There have been a lot of people explaining that this is due to what we define as live birth, like we define 22, 23-week babies as live births, whereas in other countries, maybe they start at 24, 26 weeks. But there's been enough analysis done looking at other outcomes from other countries that have kind of eliminated that. Okay, let's say we forget about these babies at the edge of viability. And it's really clear that we really do have higher rates of infant mortality than other similar states. And it's really across the board. It's not just among very preterm babies. In fact, our preterm survival rates look pretty good. It's mortality really across the spectrum of gestational ages. The other persistent issue in the U.S., which is really unique, is this extraordinary disparity in infant mortality by race and ethnicity. So here we're looking at the U.S. overall, we're looking at Wisconsin in purple, and we see that mortality rates for moms who are Hispanic or white race are around 5, and what we see here in Wisconsin, as we do across much of America, is a much higher rate. So the U.S. average for African Americans is 11, so if you were going to look at a disparity ratio, it's about 2 to 1. But Wisconsin is really an outlier here. And our African American infant mortality rates are the highest actually in the nation. This is the most recent data we have out there. It's pooled future data, and what we see is the infant mortality rate in Wisconsin is higher, for African Americans, is higher than any state in the country. I mean, we usually think about the southern states as having poor outcomes, but this is really pretty extraordinary. And if you look at the Rust Belt states, right around the Great Lakes, we see these very high rates. So, kind of overall improvements, stalled improvements in the U.S. compared to other countries, and extraordinary disparities for infants of African American moms. Lest we think this is a Milwaukee problem, it's really not. This is looking at infant mortality rates across the southeastern counties where 85% of African American kids are born. If you look at these disparity ratios, and they're very unstable because the numbers are pretty small. If you look at the number of deaths, you can see. Regardless, though, we see that these disparities are everywhere, and they're not just in Milwaukee, they're here in Dane County. And so it's really critical that we think about how our strategies impact that population. I'm sure people have been reading the newspapers a lot about the issue of maternal morbidity and mortality. Again, we rank really poorly compared to other countries. When you start seeing outcomes following a pattern, it becomes much more clear that this is real. So our maternal mortality rate down here is worse than, what can I say? Kuwait, United Kingdom, United Arab Slovenia, Serbia, Denmark, Canada, Bulgaria. I mean, we're essentially at the bottom of the pack. There's been a lot of interest in trying to understand why. There's a long history of poor data around maternal mortality. It's really hard to figure out whether a woman, when a woman died by her death certificate, whether or not it was related to childbirth. With a new checkbox on the death certificate and new linkages of death certificates to birth certificates, there's better capture of data, and I think it's becoming clear that what appears to be a rising rate of maternal mortality, which at first was attributed to better data collection, it's now becoming clear that this is probably real. What's fascinating is that if you look at most US states, this rate has continued to climb. California, and actually I'm told New York, but they didn't pull it out, are seeing declining rates of maternal mortality. Those are two states with very strong perinatal quality collaboratives, which I suspect may be a piece of that. And then Texas had a sudden increase. So most of the US is following this upward trend. Texas is taking off on its own. New York and California are seeing some improvements. So that variation is telling us there's something underlying these trends that we need to really understand. These are data from Wisconsin. This was an analysis done by Crystal Gibson, Angie Rowan, who I'm sure a lot of you know, and Katie Gillespie. They are seeing, based on hospital discharge data, increasing rates of severe maternal morbidity, which is a collection of 25 different diagnoses. Interestingly, when you take transfusion out of the equation, it's pretty flat. Anybody have any hypotheses why transfusion might be going up? What? Well, why? Okay, so I want you to think about, maybe we can talk about it later, what might be giving, what other things might be going on that can give rise to that. All right, so who in this room has seen this figure before? Okay, all right, so for the newbies to Wisconsin, you cannot leave this university without having this really ablazing. So this was developed by the Population Health Institute folks, David Kindig and Pat Remington. Have put a lot of thought into really thinking about what drives health outcomes and how can we think about it in a way that communicates the real broad number of factors that come together and create health. What's really compelling about this as a discussion tool for that we can use broadly is this kind of disentangling, what health behaviors, that's what we usually think about, right? Are you exercising? What's your diet like? Are you smoking? How much is clinical care? And then these social, economic, and physical environment factors. And so what I want you guys to take home is that clinical care, which is where almost all of the health care, which is where all of the health dollars go, is about 20% of the factors that drive health. Okay, 20%. Now that's our 20%, right? So we should really hang on to that. But there's a lot of other really critical factors. Maybe we think we can impact health behaviors. You might want to talk about whether we're the best people to influence those. But we know about half of what's determining health outcomes comes from social and economic factors in the physical environment. All right. So when we think about what we do here in clinical care, it's an important piece. 20% isn't nothing, and it's really critical that we do that well. But we also know there's a vast array of other factors that matter that we need to be able to speak to from the healthcare community. So we have this medical model, which is where I grew up, right? That's how I was trained. It's about healthcare, it's about health behaviors, and if only we could get patients to change their health behaviors, all of health issues would resolve. But really, these social determinants of health are really strongly determined by the social and economic factors in the physical environment, and in fact are probably driving a lot of these health behaviors. So it's just, for me, really critical. So if we think about these big outcomes I talked about, infant mortality, maternal mortality, kind of a simple way to think about it is healthy communities lead to healthy families and moms and create healthy babies. And that's a pretty simple but pretty accurate approach. So I want to talk a little bit about health equity, because when we think about how we can improve health, it's really critical to keep this in mind. So we talk about the social determinants of health, which is what that framework showed you, that these social factors, so the conditions, these are the words people tend to use, conditions in the places where people live, learn, work, and play affect a lot of health risks and health outcomes. Health disparities is what I showed you before. Population-based differences in health outcomes based on characteristics of groups. So I showed you disparities based on race. I could have showed you disparities based on geography, right? But the racial differences are huge, and it's really important for us to consider. The other piece that we need to really put into our thinking as we work to try to improve health outcomes is health inequities. So the WHO defines it as health differences that are socially produced. So if I were to talk about why do health outcomes look so poor for African Americans, we might need to take a step back and ask not what their health behaviors look like, or what about the healthcare piece, but really understand they are socially produced, right? There are structural factors that are driving these health outcomes. So here's one of them. So this is data from PRAMS. This is, again, that postpartum survey asking mom all about herself. And one of the things we ask in Wisconsin is, what was your income last year? And so here, we're looking at, by race, we're looking at the percent of moms who were under the federal poverty level. Anybody know what that number is for a family of four? So I don't remember what it is, but we can all agree, this isn't deep, deep poverty, but it's pretty tough to support a family below 100%. This is near poor, I think they would call it, and this is above 200%. So to be Medicaid eligible when you're not pregnant is around 100% of federal poverty level. To be Medicaid eligible when you're pregnant is in 300%. All right, so if we look at the differences by race, we see that 74% of moms who are African American in Wisconsin are below 100% of federal poverty. I don't have the data, so it's just kind of grounded in a real number. I think about that report an income, a household income of less than $10,000. Okay, so look at the difference here, right? So most white moms are above, right? Nearly all black moms are below. Huge structural difference is going to have a big impact on health. This is looking at questions about stressful life experiences. Measuring stress is really hard. There's no single way to measure, but this isn't a terrible one. Did somebody in your family die? Was there a divorce? Did somebody go to jail? So if we look at stressful life experiences, again, we see large differences by race. And again, we see African American moms have the most stressors, Hispanic moms more, and fewer among white moms. So structural differences that are likely driving this. This is sort of a little cartoony way of thinking about these differences. This is data from PRAMS for Milwaukee County, comparing African Americans to whites living in other urban counties because our sample was small, so we had to pull. And I find this a helpful way of sort of talking about differences. So we talk about health behaviors. So these are some of the health behaviors that we measure in PRAMS. So, did you take folic acid? Sort of a health behavior, sort of a medical intervention. So, we see, whites are more likely to be taking folic acid, getting exercise, having a pregnancy where they were trying to conceive. So differences in health behaviors there. Some of the behaviors that we blame all these poor birth outcomes on, like smoking and alcohol, really no difference based on race. If we look at other health, and I would call breastfeeding a health behavior, I don't know whether everybody does, but I think of it as that, so again, a little bit more breastfeeding among white moms, but not a huge difference. Back to sleep, about the same, they were co-sleeping, about the same, that's pretty low, isn't it? But no big differences based on race there. Not a lot of differences on having health insurance before pregnancy, prenatal care insurance, postpartum insurance. Kind of a big difference in first trimester and prenatal care. But this is really where the differences show up, is in these other social factors. So education. Only 4% of white moms have less than a high school education, whereas 22% of African American moms. Again, this huge poverty difference, partner-related stress. So, when I look at differences, rather than thinking, wow, maybe if we, reduce smoking or got women to exercise more, that'll improve health outcomes. Really, we see these structural differences that, if not addressed, are going to, we will fail. If we look at this, felt unsafe in the neighborhood, experienced homelessness during pregnancy. We don't even experience racism. We don't have measures of housing instability in programs, but we know the story of eviction in Milwaukee, for example, and how women with little kids are really the target group for eviction. So it's just really critical to keep that in mind. One of the things that I really like us to remember here, for those of us who are working in maternal health and maternal child health and women's health broadly, is that pregnancy and early childhood are critical periods. And there's a lot of data from a lot of different perspectives that really show that these early childhood experiences, the health of pregnancy, really sets the health trajectory for these kids through their life course. And so, whatever we can do to improve health and experiences during pregnancy is going to impact mom and mom's health, but also that kid's health really as they grow and as they develop. The economists have done a really fabulous job of trying to really put some numbers to this, because we tend to think about focusing resources. We tend to think about we focus on one group rather than another, right? And the people who are in Congress, for example, who vote on this stuff are not moms and little kids. They tend to be, from different groups, and they vote for their own priorities. But what economists have been able to show is that if we start thinking, we're gonna solve a lot of this with job training, turns out that it's a whole lot more cost effective to focus early. So focus on prenatal care, focus on early intervention programs, preschool programs, as really critical pieces of our strategy to really create a strong and vibrant community. And this is us, right? Of women's health. Prenatal care is important. So how do we prioritize solutions? So has anybody seen this health impact pyramid? Okay, so this is a really great way of thinking about a lot of what we talked about this sort of tension between focusing on health behaviors and trying to find other strategies. And this was put together by Tom Frieden, who had been the head of CDC. And what it helps us do is understand, different intersects that we can think about trying to impact in order to make a difference. So like we do, counseling and education. So I used to say, if we were trying to if we were trying to address smoking by having me see patients one-on-one in my office and counseling them and maybe giving them a prescription for a patch, we would never make the progress that we were able to make by changing the context, increasing taxes on cigarettes, changing the environment, smoke-free, indoor smoke-free rules. And so, using smoking as a way to think about these different levels of intervention, I think is really helpful. And we can take these ideas, the really critical impact of poverty, poor education, or housing inequality. If we can have an impact here, we're going to affect a much broader piece of the population. 50% of women in the U.S. who have a baby are Medicaid insured, right? So counseling and education, it's critical for things where it's necessary, where there's a large impact, but as a broad strategy, it's pretty ineffective. I like this arrow, where he talks about the size of the impact, smallest impact, largest impact. There's another arrow here that I always see when I look at this, and that is political. So to me, this is the least political, this is the most political. So, that just speaks to where we need to be thinking about how we communicate what's driving it. All right, so let's get to healthcare. So when I think broadly about strategies to improve maternal and child health, I kind of think about three pots: healthcare strategies, public health and social services strategies, and economic strategies. And they kind of, get across this framework. So today, let's talk about healthcare, because that's who we are, and we really want to do that well. Healthcare today has this increasing focus on preconception and near conception care, kind of recognizing that sometimes there are women with health issues that only we had thought about or addressed, or she had addressed before she conceived. Outcomes would have been better. Really, there's some, there are not a long list of these things, but those that are there are really critical. So, good control of diabetes has a big impact on anomalies. It's really critical. Better tailoring of anti-epileptic drugs decreases anomalies. Folic acid use prior to conception decreases neurology. I mean, we sort of have, I certainly keep a little list in my mind, these are the things that really make a difference and we want to make sure are addressed. Pregnancy planning through contraception. That's part of preconception healthcare. It's sort of hidden there because it's a little bit political to talk about contraception sometimes. But contraception helps women plan pregnancies at a time when it's best for them, either for medical reasons or social or family reasons. There's innovations in prenatal care. I don't know if Kristen Sharp is here, but we've been delivering prenatal care the same way for a long time. It was developed to monitor for preeclampsia, right? Then we started embedding all this other stuff. But there are a whole lot of better ways probably to deliver prenatal care. I know people are thinking about how many visits do we really need? Do we really need all these visits? And maybe there should be a fourth trimester, and we can do a kind of deal with things in the postpartum period. So prenatal care is being re-envisioned, and one model that I know a lot of people are really focused on here is group prenatal care, which kind of is a midwifery model that brings social support, more education to women. We've also started to realize that part of what's compelling about prenatal care is it's a place where women and the healthcare system come together. And this may not happen on a regular basis like it does in pregnancy. And so it's a great opportunity to screen for depression in the partner violence, get people caught up on their immunizations and stuff like that. There's also prenatal care coordination-like programs that state Medicaid benefit covers, for example. Some Healthy Start is kind of like that, where you're recognizing that it's a time when you're working with women who often have very chaotic lives. It's a period of change for them. They may not, it's a time when there's going to be a baby at the end, and getting stuff organized and together and set is really critical. And so programs that help connect women to WIC and other social services can be really helpful. And then there's quality improvement initiatives, which we can maybe talk about at the end, that CDC and other organizations have been working on it. We've got a perinatal quality collaborative here in Wisconsin that's trying to embark on some of that work. There's also prematurity prevention as Kara here 17P, cerclage, cervical length, I don't know where things are anymore with all of them, none of them, some of them together, but people are still working on strategies to reduce preterm delivery. And then regionalized perinatal care, which I won't talk about today, but maybe we can talk about afterwards when we brainstorm. And finally, you guys, everybody knows the story of antenatal steroids. I think there's been resolution of all the confusion about what happens if you give 2 doses. So those are really important healthcare strategies that we should do well. So, if we think, we're clinical care, that's our 20%, we really want to do that well, I thought I would share with you some data that we have that can maybe give us a little window, not into our practice, because, I don't have practice data, but at least, what does it look like across the state? So this is data, this is insurance data, and I'm kind of putting it into the healthcare bin because this is the way you get healthcare, primarily. Medicaid expansion didn't happen here, but we actually have a pretty generous badger care program for women who are documented. For women who are not documented, they can get prenatal care through CHIP to cover their unborn child. So that's kind of how the state has worked around some of these issues. So just quickly, looking at racial differences is helpful, and looking at type of insurance I think is really important. So the no insurance block is actually pretty small during pregnancy and pretty small in 2 to 6 months after pregnancy. It's not trivial before pregnancy. So about 10% of women are uninsured before they conceive. Some women are on Medicaid either because they qualified based on their poverty level or because they have a kid. And we can see that that there's definitely insurance barriers, but they're not stark, right? Most women are insured for pregnancy. But let me dive into preconception care, all right? So we did a provider survey. A lot of people in the room were involved with this, and we worked with DHS, obviously Leslie, Nicholas, a lot of people worked on this to really understand what contraceptive care looked like. It was very focused on LARC, so you can see the word LARC a lot, but LARC is sort of shorthand for IUDs and implants. And it was kind of interesting to see this extraordinary patterning in skill of inserters by specialty training. A lot of people, I always chuckle a little bit, well, why can't pediatricians put in IUDs? And I'm like, because they can't do pap smear, it's like such a long reach. So we kind of verified that, right? No pediatricians are putting in IUDs. Almost every OB-GYN is putting in an IUD. And a lot of family practitioners are. I might have thought it would be higher than that because they tend to do a lot of procedures. But we definitely see family practitioners inserting IUDs. Here we're looking overall at Wisconsin, that's a dark bar, and then comparing Dane to Milwaukee. And we see things look better in Dane County than they do in Milwaukee. Just something to keep track of. And then midwives are kind of in the middle. So skilled inserters of IUD vary by geography and really vary by specialty. Similarly with implants, again, most OB-GYNs, but not all, so there's definitely room to improve there. Can insert implants, fewer family practitioners and some. And here's where the pediatricians come in. So this is not a hard procedure to learn, and so you can imagine that they might become more important providers of implants than IUDs and midwives. So not everybody's trained to insert an implant. And training does look a little better, again, among family practitioners in Dane County. So now we're going to same-day insertion. And this would be considered to be the recommended standard of care, right? As a patient comes in, you have a conversation about method, and they say, I want an IUD, and you say, okay, let me go get it, and insert it. So there is some same-day insertion being reported by OB-GYNs, but a whole lot less by other providers. So there's definitely some room that they can improve their processes of care. So again, differences by geography and practice. Taylor Larson, I don't know if she's here, did this amazing secret shopper project where she called, I don't remember, 186 clinics. And she said, hi, I'm a new patient, and you know, I'd like to get an IUD or an implant, you know, do you guys provide them, and you know, what would that be like, you know? And so she called in Milwaukee in Dane County. And I was going to show you all the data, but there's just way too much. But, and I'll say the majority of outpatient clinics in Dane County said, sure, you know, we offer a LARC device, but fewer than half in Milwaukee County did it. So they're really different in Dane. Clinic type also varied, which isn't a big surprise, but you know, general outpatient centers, OB-GYNs, family practice, and family planning clinics are the ones who primarily provide LARCs. Internal medicine, much to my chagrin. Primary care clinics and free clinics really are not providing LARCs. So if you walk into those offices and you get contraceptive counseling, it won't be on the list of strategies to walk out. The other thing is it takes a long time. I think the average wait time for a first appointment was 21 days, which is, you know, long window, and that most clinics require 2 visits. So from the time you make that phone call till the time you get your device, you know, depending upon who you are, at least in my experience, it's not very uncommon to conceive between the phone call and the visit. So I think we could do better there. And then nearly half of clinics prefer their patients come in during their menstrual cycle. So imagine what that's like to. So first of all, this used to be the recommendation. Like back when I was bursting, you know, that was the recommendation. It's easier to insert the story. This is the story, right? But you know, like if it takes you that long to get the appointment and you have to time it with your period and you have to come back also, you know, it's just pretty crazy. So that probably is related to, you know, some of the data that we have on pregnancy intention here in Wisconsin. So, you know, pregnancy intention, as Jenny would speak to really eloquently, is a really hard thing to really get your head around. What does that really mean? But what this means is when we ask women after they have their baby, you know, did you want to be pregnant sooner or later, or when you conceived, or never? This is what they tell us. So basically, this is the percent who said, I want to be pregnant now or sooner. Okay? So we're calling them intended. And there's really, it's pretty extraordinary how few, right? So 50% overall. But there's really also large differences by race in this group as well. I don't know whether that has to do with access or different preferences about timing of pregnancy. But we do see pretty large differences. This is also a question that I find really compelling. I used to ask my moms this in the program I ran. And, you know, most moms, by the time they've had their baby, you know, a lot of kind of reframing of what they thought at the time happens. But we're seeing among African American moms, 18% are reporting that they didn't want to have that child. It doesn't mean they're not, you know, in love with that baby and thrilled to have one. But, you know, it really, they didn't want that child at the time. And that, for me, feels like a group who would really benefit from better access to contraceptive care. So what are some other aspects of preconception care? So, you know, we asked, you know, before you were pregnant, you talked to a healthcare provider about, and that's what these are. And so, you know, like we can just kind of focus on the overall. You know, did you talk about taking prescription medicine? Were you checked for diabetes or high blood pressure, depression? Did you talk about your family medical history? And did you have your teeth cleaned? This is sort of back to the whole dental pathway for preterm birth. And, you know, we can see here that, you know, most women are really not having a conversation about what we consider to be these preconception planning activities. And I'm not sure it's so different here than it is in the rest of the U.S. Well, what about prenatal care? So again, this is prams that we, you know, women are asked, you know, we look to see, did you get prenatal care in the first trimester? And here we see, again, you know, about 89% of white non-Hispanic moms got prenatal care in the first trimester, but it really does drop, and 75% is not, you know, an outstanding rate. And then women were asked if they received it as early as they wanted. And, you know, again, we see that same difference. So it really does seem to be differences in prenatal care in the first trimester, which makes it really hard to do, you know, first trimester screening and, you know, address some of these really early healthcare If we look at this index of adequacy of care, and this is essentially a total count of visits. So, if I deliver this gestational age, how many visits should I have gone to? And so adequate is considered 80% or more. Intermediate, 50 to 80%, which seems pretty low. And inadequate, fewer than 50%. Again, we're seeing, a non-insignificant percent of women getting inadequate prenatal care. We also ask women about their satisfaction with care, and let me just go to the bottom first. Women are pretty satisfied with care. Like if you ask them about the time they spend with their healthcare provider, the advice they receive, whether they felt respected, looks pretty positive. I think the only thing that stands out to me, which I'm sure everybody would anticipate, is wait time. So, how much time I spend waiting to see them. But the satisfaction measures really look pretty good. The PRAM asks about a lot of kind of anticipatory guidance that we consider to be, standard parts of prenatal care. And, I can, we can share these numbers with you guys. One of the things that stand out to me is, and it's kind of peculiar, but, we do a little bit of inverse stereotyping with our counseling. Right, so interestingly, if you look at substance abuse counseling, you're more likely to get it if you're Black or Hispanic. But who are the women with really high rates of substance abuse and opiate issues in the U.S.? You're white women. So just to call out, you're stereotyping. Of course, this population. We do it very similarly with HIV. Were you tested for HIV during pregnancy? Now, I came from a state where I'm pretty sure it was required, so it was essentially everybody got tested. So I was really surprised to see only 63% of women were tested for HIV, which seems pretty low. We're testing again more African American and Hispanic women. So we need to be really careful about stereotyping when we're doing a screening test, because screening really is designed to be used broadly. What else? Intimate partner violence screening. I'll show you some more data about that. We're doing the same thing here. So we're screening African Americans, and we're only screening half of whites. So I'll actually, it comes in a couple of slides. I'll talk more about that. Let me talk to you a little bit about 17P. So everybody knows the story about 17-hydroxyprogesterone. It was sort of an old strategy that was long lost, and somebody rediscovered it and kind of brought it back. And there have been, I think everybody pretty much accepts as pretty much good enough evidence that there's no harm and there's potential benefit to the use of 17P to prevent recurrent preterm birth in people with singleton pregnancies. And there's a lot of issues, about what's the best preparation. People used to go to the compounded pharmacy. We used to get it from Michigan. And then, I forgot the name of the company, bought it, called it Cana, increased the cost by, 300% or whatever it was. And it became a real hot political issue. But nonetheless, it's still recommended in prevention of preterm birth. And so this is some data from the provider survey that Kira has been working on with us, looking at what providers tell us about use of 17P. And again, we see, so if we look at all those people we surveyed for the LARC project, and we asked, do you provide prenatal care? Do you provide assisted delivery? We looked at those folks and asked them, do you prescribe or refer patients for 17P? And again, really, it's not 100% of OBs who are either prescribing or referring, but significantly fewer family practitioners, so that's a really important place, I think, for more education. And then midwives have to go a lot more like OBs. And then we just got some data back from the 2016 version of PRAM. So every time there's a new phase, you get to add new questions. And so we've just, I think, put this together a couple of years ago. So we now finally have questions from phase 8 about 17P. And women were asked, during your most recent pregnancy, did a doctor, nurse, or other healthcare worker give you a series of weekly shots? So this is kind of hard to get wrong, right? Like, people remember when they get these shots, called progesterone, Bacana, or 17P to try to keep your new baby from being premature.
So they can say yes, no, or don't know. So they're not going to confuse this with vaginal progesterone. You know, like people remember this. So, you know, kind of preliminary data. And Kara, I'm sure fewer than 1 in 3 said yes. So among women with a current singleton pregnancy and a prior preterm birth, we don't know how early it was, so we don't know exactly the window. Fewer than 1 in 3 say yes. Women with private insurance were twice as likely to say yes. So it looks like they're twice as likely to get 17P to prevent recurrent preterm birth. And white women and women who, white women were 50% more likely to say yes than women who were African American or Hispanic. Right, so kind of not a big surprise, but it's really kind of nauseating to see the numbers. So another place where I think we have an opportunity to do better. This is looking at intimate partner violence screening from PRAM. So I worked with Sarah Halpern-Meegan and Molly Costanza in social work and SOHI, and we looked at PRAMs and we wanted to know, well, you know, how does Wisconsin look, and then how does Wisconsin look compared to other states in terms of intimate partner violence screening? So we have more current data with more states, but this was from the 2012 data that we looked at. And so we have a map of states that ask questions about screening. You don't have to, it's not required, so each of the states did it. And you know, Wisconsin fell in the third quartile. We weren't at the bottom. We were doing a little bit better than in screening. There was huge variation. So in Utah, only about 30% of women report being screened. In New Mexico, that was the highest, about 63% report being screened, and here we are about 53%. But what's pretty compelling is that, overall in the states that we have this question, about 50% of women report being screened. About 7.6% of mothers report either intimate partner violence, or we also added contraceptive control. So I wasn't using a contraceptive because my partner didn't want me to. What we found is about 50% of women who reported non-intimate partner violence hadn't been screened. And in Wisconsin, that represented about 4.5% of new mothers. So by not universally screening, we're not necessarily, we're missing a lot of people. And while we stereotype our screening like I showed you, that's, we can't pick people out. That's why we do a screen, is because we can't tell based on our, conversation who has, who's involved with a, in partner violence. I'm gonna skip that. All right, and I'll talk about this one more thing, and then I'll have a few minutes just to chat. So I also want to talk a little bit about postpartum LARC, because I know there's been a lot of interest in the department. And I want to say from the provider survey, we found that about 80%, which is good, are discussing contraception with women during their third trimester, which is way better than waiting to deliver. About half discuss it at delivery, but fewer are discussing LARC with most of their patients. When we ask providers what they're worried about with LARC in the postpartum period, they're worried about perforation. In fact, when we were up at WAPC doing a workshop, this is exactly what we heard. The midwifery group was really worried about perforation, which is higher at the 6-week postpartum visit than immediately postpartum. So really important issue. There's a concern about expulsion, and that's real. And that's all about, what your perspective is. If 50% of people show up for their postpartum visit and the expulsion rate is a lot less than that, it's okay. But the other thing that people reported is that there are delivery facilities that won't let them provide contraceptive care after delivery. And it's a substantial percentage. And then other policies related, which is probably the same thing as this delivery facility prohibition. And in fact, when Taylor called the 10 hospitals in Dane and Milwaukee counties, what she found was there was exactly one hospital in Milwaukee County and one hospital in Dane County that offered immediate postpartum And so, where you happen to have your baby is going to completely determine your ability to get LARC, immediate postpartum. All right, so just to, kind of summarize, there's a lot of great data sources out there, so if people are interested in kind of drilling down, I'd certainly be happy to talk with you about it. We talked about health disparities by race and socioeconomic status, which are really large and persistent and really stand out here in Wisconsin. And there are health inequities by race or caste among mothers with newborns. We also know there's barriers to the most effective and well-tolerated contraceptive methods. Health insurance is thinnest during the preconception period, and few women are receiving contraceptive counseling. In terms of prenatal care, it's really nice to see women are pretty satisfied with care, so I think that's that's something to feel really good about. Access varies, and quality varies. So those are things that we need to really be thinking about. So what I'd like to do, but we have maybe 4 or 5 minutes now, but just kind of brainstorm a little bit, talk a little bit, kind of reflect a little bit on what I showed you, maybe talk about, where we might see some opportunities to improve care delivery here, to improve our results.
We're not going to use the microphone since it's not working, so just
everybody should just be really
speak loudly.
loud. Yeah.
So let's just start.
I have a question about receiving progesterone for prior preterm delivery. Was the question asked which patients did they receive or if they were offered? Because certainly there's a lot of patients who decline progesterone, especially even if the counseling that says it's unclear there's a benefit, but we know there's a risk. Patients who are, there will be many patients who decline in that setting, especially if they're prior preterm infant didn't have a lot of morbidity coverage. So I wonder if that answer would be different if that's they were offered.
So, great question. Now, so we can triangulate a little bit by going to the provider survey and asking if they offer it. So, being offered it did vary by specialties. So, and you don't have to receive care from who. But you're right, there's a lot of barriers to some of these views. One is that, people may not perceive a benefit for themselves and decline. We talked about, explicit pain and rate for injections. So I guess, I might ask, so what would good look like? Less than 1 in 3 feels like it's not enough, but how do we think about, what could our target be? And I think that's where drilling down, I think, would be really helpful. How good, where do we want, what would we consider to be good?
Thank you so much. This was perfect. It's so amazing to see essentially like an entire FPH put into one patient. I was wondering about the evidence. I don't know about this, and I was wondering if the evidence, particularly about reproduction, the racist legacies in our country around us. I wonder, does this help explain any of the inequities, particularly in a healthcare setting? Is there to what extent does mistrust as well as weirdness, wondering about LARC in Milwaukee, there are lots of reasons for that, but some of the reason, these racist legacies and how people perceive their African American patients' experiences.
Yeah, I think that's a great question. I think, we've traveled a long way on this road to try to understand this. And I certainly don't, I don't think anybody really knows what the answer is. But, I think we finally left behind the genetic predisposition to preterm birth, which was the early explanation for a lot of this, and this recognition that, this sort of, looking at the data of African American women not born in the U.S. And boy, their birth outcomes look really different than those born here. So I think all of these factors are probably at play. But I haven't seen anybody do a good job to fully disentangle it. But it's a great question. Again, the healthcare piece is small.
You know, so, you know, I'm not, you know, but certainly the stress pathway, which is sort of where people see a lot of this stuff converging biologically, leading to spontaneous preterm birth, you know, that's probably a piece of this, but you know, part of the thing that we're really interested in is, you know, some of this is post-neonatal mortality and long-term newborns, you know, so, you know, what is really going on? It's not all spontaneous preterm birth, a lot of it is, but it, you know, it's pretty complex.
So, okay, thank you. You know, one thing that you showed shocked me in Paradigms, and that is the idea that, you know, we were showing HA screening rates, and there were 60, 70, 80% something on that range. Is that not bad? Because I remember, you know, I worked in a whole bunch of hospitals over in Massachusetts, and our HA screening rates were like 99.5%. And I remember one time we had somebody who got pregnant in the middle of pregnancy, and somehow our HA test missed, and we actually had to meet with neonatology and pediatrics and the QI, thing like this, to discuss whether we should start empiric HA medications to prevent potential transmission, even though we didn't know if she was positive or not.
Yep, yeah. So can somebody speak to that, because it was mandatory where I was.
My question about that was whether that was perception. Might perceive whether or not they were tested. So perhaps it's.
Okay, so that's one explanation. Women are tested, but they don't realize it, which they should realize it, because you should be counseling women when they test them.
I think Dr. Hartman, last question for the
Yeah, I was
schedule.
also just to say thank you, and one of the things that strikes me is how well does our ethics system, you know, navigate these things and help the clinicians sort of not miss things. And practices are sort of the answer to that, but I do know from practice and the system they have, a big system, so it's like this and like that. The IGC is just right there. There's just so many, you know, I realize it's a small percentage, but that's our percentage.
Yeah.
And I just wonder, it's pertinent for people to practice how well does the ethics system actually help to make sure that all the best practices are followed?
Anybody have an answer?
What's that? Quite poorly. So,
Yeah.
so the company's overloaded.
Yeah. Every institution does their own implementation. The other thing I'll also suggest is we used to do our intimate partner violence. So if you give a doctor something to do, it happens often. If you give somebody else something to do, it might happen every time. So part of the question is, right?
My point is, so if we're the worst in the nation, you know, the health disparities, for loneliness and outcomes for African women, I mean, isn't that, you know, one place that at least gives us something that then, you know, then could be sort of best practice for the state, and isn't that an opportunity to get something really, really,
Yeah. So how do you make that happen?
I was thinking about legislation.
Well, no, I think
And
no.
actually, I was thinking about that, actually.
Okay.
And a team.
Yeah.
And,
So a quality improvement team.
And a quality improvement team, and I was thinking about Cindy Anderson and the obesity thing, and I was thinking about all of those things, which are huge, you know, compared to the nation's goals, but you see what goes there.
I couldn't agree with you more. I think some of it is about building it, and some of it is finding somebody else other than the physician to do it.
Well, yeah.
Because you know how many, like, I don't know what it's like here, because I have practice here, but the long list of stuff that shows up, you know, when I open a chart that I have to get to, you know, varicella vaccine was always there. I mean, like you can, it's really hard to check all the boxes if you are also trying to attack the patient.
Oh, absolutely.
Prioritize their agenda. But if you have a medical assistant who's grooming patients, whose job is to hand them the PHQ-9 and screen for partner violence, then it'll happen.
take care of all of that piece of it. And so the girls are made and the things are flagged.
Yeah.
And so I wasn't suggesting.
Great, but
Practicing obstetricians, I was suggesting the system.
Yeah.
Well, I was just gonna say, yes, I was using Verona, and Planned Parenthood has it because Planned Parenthood paid for it because they do not want students. Why don't we have it is because we don't have enough voice to say to Epic, look, you built this for other institutions. It shouldn't take us recreating, but to Epic, their business, no disrespect, but I will say, they are a private business, and if they, so far they've done it. Get everyone to build what they want, to individualize it for your institution, the amount of manpower and dollars that it takes benefits Epic, it does not benefit us. So we're all.
Here.
Absolutely.